Well, thank you everybody for joining us this afternoon. We're excited to have Dr. Peter Wang here from the Department of Pathology. He's an associate professor of pathology and will be reviewing the evaluation of endomyocardial biopsies for transplanted hearts. So, Peter, thank you so much again for joining us, and excited to see what you have in store for us today.
Very good. Thank you so much for this is pretty exciting for me too, because I really want to coordinate and discuss with our cardiologists. Can you guys see my screen okay?
Yep, we see it just fine. Mhm.
Very good. So this is outline. I understand it's only 30 minutes talk, but I still want to introduce both cellular acute cellular-based rejection and antibody-based rejection. Then close to our heart, how the yield pathology do during over the last couple years. And then I will touch base on a few important and interesting discussion in the field. Stop me anytime if you have questions. I think you guys are very familiar with this slide. So cellular mediated rejection is still defined by pathology, at least for now.
Yeah,
Some new
Peter,
technology.
we're just seeing the first slide still. I don't know if we just see the PowerPoint and the first slide that says pathological evaluation. Yeah, there we go. Okay.
You see the second slide now?
Yeah, yes, now we see it. Yep.
Okay. So these are procedure are very familiar with you. I do not need to discuss anymore. So this is what you do routinely. But one important, can you see this slide?
Yes, yep.
Okay. So these one point I want to emphasize, there are at least 3 right ventricle samples are expected from pathologists. That's why sometimes you can see the sampling is suboptimal because only 2 or only 1 is identified. So ideally, we need 3, and if we go to 5 samples per patient, that has documented that could improve in sensitivity. And this is the acute cellular rejection system. It's, we got it updated 2004. Sounds like today talking about 20 years ago. The other day when I present this in a pathologist meeting, several people come to me, why don't you guys update it recently? Because in renal, they upregulated every 3 years. But I think these are pretty good for a cardiovascular pathologist. We classify the rejection into 4, 0 to 3R. It's pretty straightforward, simple. 1R and 3R. 1R, you don't need to do anything. 3R, we need to treatment. And if we end up in 2R in the report, we need some discussion and to see the clinical presentation before we make any decision. So what is the 1R? This actually is 0. So in routine heart, you can see this our routine heart. In the center, you have either coronary artery or coronary vein. But as you can see, the endothelial cells are very flat. You're almost not possible to see the endothelial cells. And you can see in between cardiomyocytes are very tight, very minimal space you can see here. And then in other heart, you may see some fatty metaplasia, as we can see here. It is also acceptable. And sometimes the transplanted heart from aged donor, like 50 years or so, they could have a fibrosis that is also acceptable. So what is 1R? 1R is something the lymphocyte, especially T lymphocyte, extravagate from the vessel. They could present in several formats. First format you see, this is a small coronary artery. Surrounding that, you have one layer of lymphocyte and no cardiomyocyte damage in surrounding. This is 1R. And second format, you see this is a venue, this coronary venue here. And surrounding that, you have several layers of endothelial lymphocytes. This is also 1R because there are no cardiomyocyte damage and it's not diffuse yet. So there's another conceptually a little bit challenging is this type of 1R. This type of 1R, you can see interstitial, you have a lymphocytes. It's kind of diffuse. You can see here, it's all over the place in this area. However, the distribution is kind of sparse. You do not see much lymphocyte in each line, and it basically have no cardiomyocyte damage. In this one, we still call 1R. In previous days, these are classified grade 1RB or 1B, which somebody still insist this have a clinical implication, but current consensus is this still belong to 1R. So any questions so far? Very good. So before I introduce 2R, let me introduce cardiomyocyte damage. Cardiomyocyte damage are illustrated by this picture, as you can see here. Bottom line is you can see the lymphocyte start to infiltrate into the cardiomyocyte. So various things happened into the cardiomyocyte. Obviously, you see here, the cardiomyocyte become bifurcation. So this is one type of damage. Another damage you can see is clearing of cytoplasm. So this area compared this is clearing of cytoplasm. And then you can see the cytoplasmic membrane is infiltrated by the lymphocyte. We call that myocyte encroachment. And finally, you have cardiomyocyte drop off. You can see here, only a central cardiomyocyte there. Majority of cytoplasm already disappeared. All these are classified as cardiomyocyte. So remember, in 1R, we only allow a maximum one focus of cardiomyocyte damage. And if you have a two or more than two foci of cardiomyocyte damage, we call that 2R. Let's go to a couple example. This is the problem of because this slide is not in a presentation mode. Let me show this one first. So in this slide, you can see this is a lymphocyte in cardiomyocyte. This in cardiomyocyte. Clearly, there's some cardiomyocyte damage. You see the clearing here. You see the encroachment here. So there's at least two foci, but they're not diffused together. This is clearly a 2R. Then the question comes here. You have one big site, which is one focus of cardiomyocyte damage, and then this one cardiomyocyte may be area-wise equal to two, like in the other side we just discussed. So in this situation, we still call that 2R because it's not diffused together yet. And we do have a clearly cardiomyocyte damage. You can argue this is one focus, this is not a focus. So this is still 2R. So this is in sharp contrast to 3R, because in 3R, that is something we definitely need clinical management. This is what 3R illustrated as here. You can see the interstitial, you have a lot of cardiomyocyte. Each side, you can see cardiomyocyte damage. And these damage are fused together, all linked together, at least in this focal area. This in the interstitial, you have a series edematous changes too. You can see the pale, not in the cytoplasm, but in the interstitial area. You see the pale. So same thing here. You can see lymphocyte all over the place with cardiomyocyte damage and with edema. sometimes we just discussed majority of time the infiltrated lymphocyte. But in 3R, you start to see neutrophils, eosinophils, and polymorphic edema change. And sometimes even you can see here, this is so-called micronecrosis here. So these are all 3R. When pathologists see a 3R rejection, we call you guys immediately and say this need to be treated. So this is 3R. So any questions for the grading so far? That are basically my introduction for the acute cellular rejection. If that is all, I think the job for pathology is too straightforward. Things are not that straightforward. There are something like acuity effect. These are so-called mimickers for rejection. So this acuity effect, you can see the lymphocyte infiltrate either totally on the surface of pericardium or start from pericardium, penetrate into this cardiomyocyte. You can imagine if you do not, if biopsy doesn't include the pericardium surface, it's pretty challenging to tell this is 2R, 3R, or acuity effect. So that's why in doubt, we do these immunostains, which illustrate both 3D, CD3, CD20, CD68, and CD21. This is in case we cannot be 100% sure the acuity versus a rejection. So we mentioned majority of rejection is CD3 T cell, but in acuity effect, we have significant number of B cell, especially in the center of the lesion, as we can see here. And CD21 is the tertiary follicular structure, as we can see here illustrated, and CD68 is evenly distributed. When we see that, we are pretty sure this is the acuity effect. It's not rejection. This is another example. As we can see, more and more heart may come from aged patient, or even for young patient, this maybe have some cold time, so-called cold time, not maintained in a proper solution yet. At least a couple of years ago, the solution is not that widely available. So you can see focal area of fibrosis, and surrounding that, you can see lymphocyte infiltrate. So that may cause a problem. It's 1R or it's only ischemic injury. In this case, it's ischemic injury because you can see the lymphocytes are totally within fibrosis. So obviously you need some practice, and you can see the ischemic change of the fibroblast stroma cells, and these are indicating of ischemic injury. I think probably main question and major concern for cardiologists, so-called cardiac allograft vasculopathy. This is a research field is pioneered here at Yale. This has been studied for 20 years or so. And this is the, we call that accelerated atherosclerosis, because it's concentric, as it have a lot of lymphocyte infiltrate, and this can cause ischemic damage, and it is a major reason for long-term heart survival. So one good thing I think in the cardiac biopsy, not all the time, but sometimes we can evaluate small coronary arterioles. So we can evaluate this process, although this need to be better defined in the near future. So compared to acute cellular rejection, a relatively poorly defined entity is antibody-mediated rejection. So these are so-called morphological change of antibody-mediated rejection. First one is this one here, highlight is inlet. As we can see, we discussed initially in normal heart coronary artery, small artery, the endothelial cells are very flat, but you can see here is perpendicular, very prominent. And in the lumen, you have some macrophages. And in the interstitium, you can see a very strong edema here, and you have lymphocyte infiltrate, but not that impressive. If this antibody-mediated rejection is stronger, you can see the capillaries or venules or arterioles broken. You can see hemorrhage here. So these are morphological features of antibody-mediated rejection. So in summary of the morphology of antibody, these are two types. One is intravascular changes. You have prominent endothelial cells and you have mononuclear cell within the lumen. And in severe situation, you have a hemorrhage, interstitial edema, myocyte damage, and hemorrhage, everything. So in our practice, we always use a complement dimer. One is C4D, another one is C3D. Using this one as index for antibody-mediated rejection. And this usually take 1 more days or at least 12 hours. So we always report it 1 day later. So cutoff here is for C4D. If it is positive, it need to be positive more than 50% of capillaries or vessels. If it's a CD68, we need more than 10%. That will be okay. So more and more, because of convenience, more and more practice, including Yale, are using immunohistochemical instead of immunofluorescent. This is what we see immunohistochemical, C4D here, and CD68, which highlight macrophages. We can see here in this in light, macrophages in the lumen. So this is a 2013 classification for the cardiac antibody-mediated rejection. Basically, we divide it into 3 categories. One are PAMR1 could be divided into histological only or immunopathological only. Basically, you don't need to have both of them, and if you have both of them, you call that AMR level 2. So if you have both of them and you have a morphological change of interstitial hemorrhage, capillary fragment, inflammation, endothelial necrosis, these are 3. And this is the scheme we report. But as you know better, or even well known, that more pathological change of AMR is only one piece of the puzzle. We need a circulating donor-specific antibody, and we need signs of graft dysfunction before we make any clinical intervention. So that's pretty much, I think, classically what we do for ACR and AMR. So any questions? Okay, so from 2018 to 2025 years time, at Yale we have about 1,500 cardiac biopsy. Among them, 1% more than 2 are, and 0.1% are antibody positive for antibody-mediated rejection, and this is what we see. Like you can see here, this C4D in this at this level, this is like a 4 scanning power, and at higher power, at 400-fold, you can see the endothelial cells here, capillary are positive. All these small capillaries are positive. So that is one case of AMR positive case. So over the years, pathology, including cardiovascular and transplantation pathology, does evolve over the years. And as I'm sure everybody knows, we are talking about imaging, digital assisted pathology. This applies to cardiac pathology too. This is a one program, 2020, somebody from Mass General and Greek, they collaborate, design some algorithm called screen. As you can see, they can capture both cellular rejection and antibody-mediated rejection. They highlight in cellular rejection, they highlight infiltrate. In antibody-mediated rejection, they highlight interstitial edema and capillary enlargement. Second thing I think close to my heart is the so-called circulating biomarker. And many people believe this will someday at least take majority part of rejection monitoring, especially in the stable patient. So I think it started with donor-specific circulating cell-free DNA, and this is one of the earlier study in 2022. As you can see here, the area under the curve, it is better for antibody-mediated rejection 0.95 than cellular-mediated rejection, which is 0.89. Unfortunately, at least by then, they cannot differentiate antibody-mediated versus cellular-mediated. So they are still working on ways to differentiate using this marker. They're talking about DNA methylation pattern. So personally here, I think at Yale, we're talking about exosomal-based approach. I think we have a recent publication in that direction, try to differentiate it. I think our method, exosomal-based, is better. We focus on acute cellular-based rejection, which have a pretty good prediction power, prognosis power. So the last item, progress in this area, I think you guys will be interested is so-called genetically modified porting to human cardiac xenograft transplantation. We know it's lasted for about 60 days, but it is very interesting to see what the biology showed up. So actually the biology showed up, you'll see the panel A is a normal, like a genetically modified pig heart, but at day 50, you can see a lot of edematous changes. And so we do not see much infiltrate and some hemorrhage here too. At the third, and by day 53, we can see some area, this interstitial edema start to be fibrotic. In the fibrotic area, we have some infiltrate. And at the time of autopsy, which is D and C, we can see the edema, fibrosis, and see some hemorrhages. These type of change are pretty similar to what we call hyperacute rejection in human body, which I think we have controlled very well, is not common at all in daily practice nowadays. So it'll be interesting to see what in this direction, what more we can learn. But that is what our experience so far. So that's pretty much what I have to talking about. I'm very happy to answer any questions.
Thank you, Peter. That was really, really good. Does anybody there in the listening audience have any questions for Dr. Wang? One thing I was just wondering was that you'd made mention about the length of time since there's been an update to the staging for ACR. You know, as a pathologist, I mean, what would make sense to you in regards to there needing to be any updates to the staging system? Do you feel there needs to be a higher degree of granularity? Are you oftentimes find putting things that are, you know, that appear to have significant differences within the same categories? And I guess take it from there if you would. And which I'm interested to see what your thoughts are about that.
Yeah, I think every 5 years you update a grading system is very reasonable. I think the question here is because there are so many development in the fluid-based assay instead of a morphology-based assay. So people put too much interest in the fluid instead of focus on morphology. See, these like there are many questions in the morphology. Like I just mentioned, like a 2R, we say 2 foci of cardiomyocyte damage. How about one very big focus, and is the area wise is more like equal to 2? How do we deal with that? So I think there are many things we need to be more quantitatively defined than just like a talking area. So I think some great scientists say without put things into number, we're not talking about science, right?
Mm.
But that's state of art for cardiac pathology. I think there are many room to improve in this direction.
Yeah, well, thank you.
Luckily, I'm in the national team on this, so I'm partially responsible for this. But I will
Okay.
fight for it for sure.
Well, best of luck to you. That's fantastic. Anybody else in the crowd have any questions? Well, if not, thank you again so much for your time today and sharing, all this information with us. We're really grateful and appreciative for your talk.
Very good. If anybody have any question, just email me. I know your guys' time are very limited. You can email me, ask any questions. I'm very happy to answer and discuss. Thank you,
Sure.
guys.
Thank you so much. Have a great day.